Ever been faced with a medical term that just, stops you in your tracks? Maybe something on a discharge form or you overheard it, like chest tube?
Hmm.
It sounds serious, important, but like, what is actually going on there?
Yeah, that feeling of being a bit in the dark,
Yeah.
that's exactly what we want to clear up here on the deep dive. Think of this as your shortcut, really,
Yeah.
to understanding these complex topics.
We do the sifting for you.
Exactly. So today we're tackling chest tubes. And our guide is this great, really practical explanation from an experienced ICU nurse.
Right. This isn't textbook theory, is it? It's more like a trenches level knowledge.
Absolutely, what you'd learn on the job. And our mission today is, well, pretty simple, demystify chest tubes for you.
So you can really grasp what they are, why they're used.
And what all those tubes and gadgets attached are actually doing.
Okay, let's dive right in then. So what are chest tubes? Just the basics.
Okay, so essentially they're long, clear plastic tubes.
Yeah.
They're flexible, but still kind of semi-stiff, and they get inserted into the pleural space. Now that's the space between the two thin layers, the pleura, that surround your lungs.
Okay, between the layers around the lungs. And why put a tube there? What's the purpose?
The main reason is to drain stuff that shouldn't be there, either fluid or air that's collected in that space.
Ah.
And when you drain that collection, it gives a compressed lung, lung that's being squeezed, the chance to inflate fully again.
That makes total sense. So what kind of specific situations lead to needing one?
Well, there's several key ones. A big one is a pneumothorax.
Which is air, right?
Right, air trapped in that pleural space.
Right.
The material we looked at even mentioned a case, a young person who just didn't feel right.
Yeah.
And bam, collapsed lung. But pneumothorax can also happen after things like putting in a central line or any chest surgery, obviously trauma,
Makes sense.
or even sometimes after a difficult intubation, putting in a breathing tube.
Wow. Okay. Quite a list.
Yeah.
And the source also flagged a really dangerous type of air collection.
Yes, the tension pneumothorax. That's a true emergency, life-threatening.
What happens there?
Basically, the trapped air builds up so much pressure, it actually pushes everything in the middle of your chest.
Yeah.
Your heart, big blood vessels, the trachea pushes it over to the other side.
Ooh.
Yeah, it squeezes the hardened blood vessels, needs very, very fast recognition and treatment.
Definitely sounds critical. Okay, what else besides air?
Well, you can get blood collecting there. That's a hemothorax,
Okay.
often after surgery or, again, trauma.
Uh-huh.
And sometimes you get both blood and air. We call that a hemopneumothorax.
Pneumothorax. Got it.
Then there's pus, which is called an empyema,
Okay.
and just general fluid collections. Those are pleural effusions.
Effusions. Yeah, you hear that term. What kind of fluid is that usually?
It can vary. Often it's serous,
What?
which is kind of thin, watery. Congestive heart failure is a really common cause for that type.
Right, the body's fluid balance is off.
Exactly. But tumors can also cause effusions. The source mentions a difference between transudates and exudates. Think of transudate as thinner fluid, like from CHF, more of a leakage issue. Exudate is usually thicker, more related to inflammation or infection, maybe a tumor. It gives clues.
Interesting. So the fluid type tells a story. Now, where exactly do these tubes go in? It sounds pretty invasive.
It is a surgical procedure, yeah.
Yeah.
Usually done by a surgeon, thoracic, or maybe general. And the common spot is between the ribs, the fourth or fifth intercostal space.
Okay.
Kind of along the side, mid-axillary line. But where you'd level a transducer for an art line, actually.
Oh, interesting connection. And the direction it goes inside, does it just go straight in?
No, it depends on where the collection is. The surgeon will aim it maybe upwards and towards the front or upwards and towards the back to get right to where the air or fluid is pooling.
Right, targeting the problem. Okay, now this 3-chamber system, or pleurevac, that sounds like it could get complicated.
It can look a bit daunting, yeah, especially the modern pleurevac units with all the compartments. But the basic idea, the principle, it's actually quite clever and comes from an older system using like 3 separate bottles.
Mm-hmm.
The pleurevac just puts it all together in one box.
Okay, so let's break that down. The source started with a single bottle idea, an air trap.
Yeah, that's the perfect starting point. Imagine just having the chest tube open to the air. Bad idea, right? Patient breathes in, sucks air into the chest.
Right.
So the air trap puts the end of the tube underwater in a sealed container. Air can bubble out from the patient through the water,
Okay.
but the water stops air from being sucked back in. It's a one-way valve.
Like a water seal?
Exactly. And if you see bubbles there, that usually means air's leaving the chest. We call it an air leak.
Okay, got the one-way valve.
Yeah.
How does the pleurevac build on that with 3 chambers.
So in the old 3-bottle way, bottle 1 just collected the drainage, whatever was coming out, blood, fluid, pus.
Right.
Bottle 2 was that water seal, the air trap and leak indicator we just discussed.
Hmm.
And bottle 3 was used to control the suction. The pleurevac just combines those jobs into different sections of the one unit.
Okay, so chamber 1 in the pleurevac drainage collection, the source said this can fill up fast sometimes.
Oh, absolutely. Especially with certain effusions, like from
Yeah.
tumors. You could drain a liter, maybe even 2 in a day.
Wow.
And when that chamber gets full, you have to change the whole pleurevac unit out.
And that's when clamping might happen, briefly.
That's like the one time the source mentions briefly clamping, just while you swap the units. And you have to remember to unclamp it right away. Super important.
Got it. Very specific reason, very brief time. Okay, chamber 2, the air leak indicator, that's our water seal chamber. Bubbles mean air coming out?
Generally, yes. Bubbles there usually mean air is leaving the pleural space. Good sign if you're treating a pneumothorax.
I sense a but.
Yeah, well, the source makes a really good point.
Mm-hmm.
Those bubbles don't always mean the air is coming from inside the chest.
Oh, interesting. Where else could it be from?
Could be a leak in the tubing itself, somewhere along the line.
Yeah.
Or, and this is important, if one of the side holes on the chest tube,
The holes that are supposed to be inside the chest?
right, if one of those accidentally slicks outside the chest wall, the tube can just suck room air in. And you'll still see bubbles in chamber 2.
Ah, okay. So bubbling isn't the whole story. You got to look at the patient, the tube placement.
Exactly. Context is key.
Now, chamber 3, the suction control. How does that work? How does it regulate things?
Okay, this is the really clever bit for regulated suction. You connect wall suction, from the hospital system to this third chamber.
Right.
Inside that chamber is a column of sterile water. The wall suction pulls air through that water, but the height of that water column determines the maximum suction the patient actually feels.
So the water level sets the limit, like 20 centimeters is common.
Precisely. The surgeon orders a specific level, often 20 centimeters could be different. And here's the thing, cranking up the wall suction doesn't increase the suction on the patient past that water level.
It just makes more bubbles in that third chamber.
Exactly. More bubbling there just means the wall suction is pulling air through the vent harder. It's noisy, and it evaporates the water faster.
Ah, and you need to use sterile water to refill, not saline?
Correct. Saline can apparently leave crusty deposits over time. Sterile water is the way to go. Keep that level topped up.
Good practical tip. Now, can this suction, even regulated, ever be bad?
Well, yes. Uncontrolled suction would definitely be bad. That's why the surgeon's order for that water level is so crucial. Too much pull could potentially, injure the lung tissue.
Makes sense. Okay, troubleshooting. Let's talk more about those air leaks. When are they good? When are they bad?
Okay, so initially, like right after putting a tube in for a pneumothorax or after lung surgery, like a biopsy or removing part of a lung,
Yeah.
seeing an air leak, seeing bubbles in chamber 2 is generally good. It means the air that shouldn't be there is getting out.
Okay, so you want to see it then?
Right. If you don't see a leak when you expect one, maybe the tube's not in the right spot or it's blocked.
Okay, so when does an air leak become a bad sign?
Well, if it just keeps going, like say 2 weeks after a lung biopsy and there's still bubbles, that's persistent.
And that means?
Could be a leak in the tubing system itself, maybe a loose connection, or, more concerning, it could mean a bronchopleural fistula.
What's that?
It's an abnormal connection, like a hole between an airway, a bronchus in the lung, and that pleural space.
Oh, wow.
Yeah, it can happen sometimes, maybe especially if someone's on high ventilator pressures. The pressure makes it hard for things to heal.
That sounds tricky to manage. Okay, the source also mentioned a little black button on the pleurevac.
Ah, yes, that button. It's for lowering the water level in the air leak chamber, chamber 2.
Why would you need to do that?
Sometimes if a patient takes a really deep breath or coughs hard, they can generate a lot of negative pressure inside their chest.
Okay.
That negative pressure can suck the water from the air leak chamber up into the tubing that connects to the patient.
And that's bad because
Because that higher water column increases the resistance, making it harder for air to bubble out. So you press that black button, it vents the chamber, lets the excess water drain back down to the proper level marked on the chamber.
like resetting the baseline for the air to escape. Got it. Now, what about tube stripping? Sounds vigorous. Source said it's controversial.
It is very controversial. The idea behind it, milking or squeezing the tube, is to try and dislodge or prevent clots inside the tube.
To keep it draining.
Right. Because if it blocks, especially with fluid or blood, it can't drain air or fluid, and you could end up back where you started, or worse, like a tension pneumothorax.
But the controversy
The
is...
stripping action itself can create really high, like dangerously high negative pressures inside the chest momentarily, potentially damaging the lung.
Ouch.
So the absolute rule is
Yeah.
follow the surgeon's orders. Some want it, some definitely don't. And always watch for drainage. Just stopping suddenly, that could mean a blockage.
Right. Surgeon's call. Okay, let's revisit tension pneumothorax. Recognizing it quickly is key. What are the big warning signs?
Okay, look for blood pressure dropping, so hypotension. Skin turning bluish, cyanosis. Obvious difficulty breathing, working hard to breathe.
Okay.
And maybe you might even see the windpipe, the trachea, shifted over to one side in the neck.
Wow, visibly shifted.
Yeah, and if they have an arterial line measuring blood pressure continuously,
Yes.
you might see something called pulsus paradoxus.
Pulsus paradoxus. Okay, break that down for us. Sounds complicated.
It sounds it,
Yeah.
but the idea is pretty straightforward. It's when the systolic blood pressure, the top number, drops abnormally low when the patient breathes in.
More than usual.
Yeah, way more. Normally it might dip just a tiny bit. With pulsus paradoxus, we're talking a drop of, say, more than 15, maybe 20 points.
And why does that happen in a tension pneumothorax?
Because when they breathe in, that already high pressure inside the chest gets even higher, squeezing the heart even more.
Oh.
So the heart can't fill properly, can't pump as effectively, and boom, the blood pressure drops significantly with each breath in.
So seeing that big drop on the art line waveform with inspiration
Is a huge red flag. Major indicator of severe pressure on the heart, like from a tension pneumo.
Got it. Critical sign. Now, clamping chest tubes. We said briefly for changing the system generally, though.
Generally a bad idea. The source is clear. Avoid it. The only other time mentioned is if the tubing accidentally disconnects from the pleurevac,
Okay.
then you clamp the tube itself really quickly, just long enough to grab a new sterile connector or pleurevac and hook it back up. Prevents air sucking in.
But otherwise, keep it unclamped.
Keep it unclamped. Prolonged clamping risks the air or fluid building back up.
Right. What if, the tube just gets pulled out accidentally, patient moves, something happens?
Okay, immediate action needed. You got to cover that hole fast.
Yeah.
Use sterile gauze, ideally with petroleum jelly on it, Vaseline gauze.
To seal it.
Exactly. Make an occlusive seal, stop air rushing in, then stat page the surgeon and get a chest x-ray ordered, like right away.
Seal, page, x-ray. Got it. Okay. Water seal. What does that mean? Is that different from the water seal chamber?
It's related. Going to water seal means you disconnect the wall suction from the pleurevac.
So no more active suction.
Right. The system is still connected to the patient. That chamber 2 water seal is still acting as the one-way valve, but there's no negative pressure being applied from the wall.
And why would you do that?
Usually it's done when the air leak is stopped or the fluid drainage is slowed right down, maybe after surgery or after a pleurodesis.
Pleurodesis.
That's a procedure where they try to make the lungs stick to the inside of the chest wall using talc or something to prevent fluid or air coming back.
Okay.
So you go to water seal to see if the lung stays up, if things reaccumulate without suction. Monitor closely, get x-rays. It's often the step right before taking the tube out completely.
Makes sense. Testing the waters, literally. Another term, subcutaneous emphysema. Sounds crackly.
It feels crackly. The source describes it perfectly, like Rice Krispies under the skin when you press on it.
And what is it?
It's air that's escaped from the chest, maybe from around the insertion site, or if the tube isn't placed quite right, and it gets trapped in the tissues just under the skin.
Is it dangerous?
Usually the air gets reabsorbed once the leak is fixed, but it can cause a lot of swelling, sometimes dramatic swelling of the face, neck.
Like in that picture in the source material?
Exactly. And if that swelling is severe around the neck, it could potentially compress the airway. So that needs immediate assessment, maybe even intubation if the airway is threatened.
Okay, so watch for swelling, especially neck and face. Phew. One last thing mentioned, streptokinase, using that with chest tubes.
Yeah, streptokinase is a clot-busting drug. Sometimes, especially with narrower chest tubes, they can get blocked up with fibrin, which is part of a clot.
So you instill the drug.
Right, usually through a little stopcock port on the tubing. It helps dissolve the fibrin blockage, gets the tube draining again. It's also used sometimes for loculated effusions.
Loculated, meaning walled off.
Exactly. The fluid is trapped in little pockets by fibrin membranes. Streptokinase can help break down those membranes so the fluid can actually drain out. The source mentioned a typical dose, like 250,000 units.
So it helps clear blockages or break down compartments, another tool in the toolbox.
Precisely. When simple drainage isn't cutting it.
Wow. Okay, that was a lot, but incredibly helpful. So just to recap the big things. Chest tubes drain air or fluid from around the lungs.
Right, letting the lung re-expand.
The pleurevac uses that clever three-chamber system collection, the water seal or air leak spot, and the suction control chamber with the water level.
Yep, the water level being key for regulating suction.
And watching out for problems is crucial, persistent air leaks, signs of blockage, and especially recognizing attention pneumothorax quickly.
Absolutely vital. Those are the main takeaways.
I think maybe the aha moment for me was really understanding how that water column controls the suction. It's not just arbitrary bubbling.
Yeah, it's a neat bit of physics, isn't it? Or maybe understanding pulses paradoxes, seeing how that blood pressure drop directly relates to the pressure inside the chest.
Definitely. I feel like, I've gone way beyond just it's a tube in the chest. There's so much mechanics and physiology involved.
And that's the goal, right? To give you that deeper insight, that practical understanding of the why and how.
Fantastic. So, as we wrap up this deep dive, maybe something for you, the listener, to think about. Medicine is always changing. How do you think chest drainage might evolve?
Hmm. Interesting question. Smaller tubes, maybe? Different ways to manage suction?
Yeah. Or what other complex devices out there have these kinds of, elegant principles behind them? It makes you really consider the why behind these interventions.
Definitely food for thought.